Okay. Renal small vessel vasculitis. What does this mean first? What does this capture? Okay, everybody thinks about ANCA-associated vasculitis, but let's think of it more broadly so that we could put things into a systematic understanding, uh, so that, we can build knowledge as opposed to try and just have the spaghetti stick to the wall. Okay, so I might have posse immune small vessel vasculitis. Okay, let's highlight first the title, small vessel vasculitis. Okay, so this is not, you know, Takayasu's. Okay, this is not um, um, the my what's it? This is not polynodosa, right? So this is again, small vessel vasculitis. That means it can involve the glomerular tuft. It can involve pulmonary capillaries. It can involve skin, where you can see purpura, but you would not see polyarteritis nodosa with purpura, right? Typically, unless it was a weird case. That implies there's a small vessel involvement, right? And polyarteritis nodosa will not involve the glomerular tuft. It would involve the more proximal medium vessels, right? So this is, again, narrowing our conversation to small vessel vasculitis. That being said, we even have a case of GPA with some aortic involvement, but also had small vessel vasculitis. So there is some, blending of these conditions. But, that being said, let's focus on the small vessel vasculitides, which are certainly much more common than polyarteritis nodosa. So posse immune small vessel vasculitis. Posse immune tells you, the characteristic. There's no immune complexes on EM or immunofluorescence, right? And then let's contrast that against the small vessel vasculitides with immune deposits. What would be an example of that? Well, anti-GBM disease would be an example of small vessel vasculitis with immune deposits. Cryoglobulinemia would be another one. I guess I didn't go through, those individually. I just highlighted it here. Anti-GBM, cryoglobulinemia. We covered HSP as an example of small vessel vasculitis. Serum sickness would be another one. Lupus can do this. Behçet's, very rarely. And then drug-induced small vessel vasculitis. We've had a couple of those where someone was on um, their hydralazine and presents with a small vessel vasculitis. You can maybe characterize the levimazole induced small vessel vasculitis as a form of drug-induced vasculitis. All right, so posse immune, small vessel vasculitis is the one we'll cover first. Again, this is a condition that involves the capillaries with some bleed over into the smaller arteries. And again, there's no immune deposits on immunofluorescence on electron microscopy. Now, the differential of this would include the ANCA-associated vasculitides, GPA, eGPA, and microscopic polyangiitis. Sometimes you don't detect an ANCA, but it's posse immune, and you just call it, idiopathic posse immune small vessel vasculitis. Drug-induced vasculitis, which we've already sort of covered. Typically, these do have non-specific, especially levimazole-induced small vessel vasculitis, often has ANCAs that are positive, and often it is both P-ANCA and C-ANCA. Sometimes you can have atypical ANCAs that are not directed to proteinase 3 or myeloperoxidase. Okay. And then there's also a well-described form of small vessel posse immune small vessel vasculitis that occurs with anti-TNF drugs. We've had a couple of those. Rheumatoid arthritis can also be associated with a vasculitis. Okay. Now, generally, there's ANCA positivity. There is a little bit of specificity for these ANCAs, but it's not perfect. GPA often has positive ANCAs, and typically it's directed to proteinase 3, but not always. If you have somebody who has an antibody to myeloperoxidase, but has um, tracheal involvement or involvement of the nasal cartilage, in general, those are going to be called GPAs, even though they're myeloperoxidase positive. So the clinical syndromes out, or the clinical presentation or pathologic involvement will trump the autoantibodies that you detect in the periphery. Okay, eGPA is a less consistently positive for ANCAs, but when it is positive, it's more commonly associated with anti-myeloperoxidase antibodies. What does the pathology look like? Well, we see varying degrees of necrosis, but we usually see crescents on kidney biopsy, okay? And once again, immunofluorescence and EM are negative. So here are some examples of how these may manifest. In this left panel, you can see areas of necrosis. Okay, this is obviously a silver stain. This smudgy pink stuff is the necrotic segment of this glomerulus. Okay, so this is an area of necrosis, right? And then you can, of course, have the crescents that are present. Discriminate this, try to wrestle through this uh, as you are discriminating this with the collapsing glomerulopathy. Sometimes those are two diagnoses that can be confused based on histologic findings. If you see a gap between Bowman's capsule and this extra glomerular hypercellularity, that would be more swaying you towards a collapsing glomerulopathy. But if you see no gap, then one would be more inclined to call this a crescentic glomerulonephritis. Okay, there's also typically different appearance to the extracapillary hypercellularity. There may be proteinaceous droplets that are present in these extracapillary cells in the collapsing glomerulopathy. You don't see that on in cellular crescents. Now, you can also have more fibrocellular crescents in the chronic phase of these crescentic GNs. Okay. Pulmonary manifestations are common in the ANCA-associated vasculitides. And again, when you have this upper airway involvement, GPA is that's highly specific for a diagnosis of GPA, okay? Limited GPA can, however, be described where, I only have pulmonary involvement. There is some predilection for, or there is some gender differences in this form of presentation of GPA. But obviously those are not patients that we're going to see. So I won't belabor that, except when they maybe evolve into a more multi-system disease presentation. Musculoskeletal involvement can be present with these non-specific myalgias and arthralgias or frank arthritis. Again, when I have purpura, that is your clinician clinical clue that this is a small vessel vasculitis, and that opens up your differential to that list of possibilities. This can also present with ulcers, nodules, but again, the typical is purpura, and on biopsy, I see leukocytoclastic vasculitis. Remember, HSP would also see purpura and leukocytoclastic vasculitis. You have to ask for immunofluorescence because it's not standard, part of skin biopsies to look for IgA deposition to make the diagnosis of HSP as opposed to pauciimmune vasculitis. Okay, nervous system involvement can occur. the classic being mononeuritis multiplex. Cardiac involvement can occur. And there is a little bit of specificity for cardiac involvement for EGPA. You can have ophthalmologic involvement. We had an interesting case of someone who had a smoldering course, um, primarily manifesting with eye periorbital inflammation that was dragging on for years, and then ultimately started to develop renal manifestations later on. But that is a well-described presentation of these paucium vasculitides. Commonly, these patients have DVTs, interestingly. So, we don't have routine practice of anticoagulation, but it is a known feature of the ANCA-associated vasculitides. And then the eosinophilia is characteristic of EGPA. And typically, EGPA presents with a prolonged phase of atopic manifestations like asthma or eczema, and a peripheral eosinophilia that can go on for even a decade, right, before manifesting vasculitis. Okay, so you can first have this, again, eosinophilia, and sometimes you never paid attention except in the retrospectoscope, where you see this persistent eosinophilia that gives you the clue that, hey, this looks like it may be a case of EGPA. Okay. You can see elevations in IgE, and there is even some therapies that are used by allergy and immunology that are directed against this this uh, pathway of autoimmunity that are used for asthmatics, refractory asthmatics, where they're using certain IL interleukin blockade. I've seen that used in some of the EGPA cases. Okay. Um, Prognosis. Generally, we can achieve remission in most patients. Okay. And this comes from some of the randomized controlled trial data. In 90% of patients, we're able to achieve remissions with induction lasting either 3 or 6 months. So here we're back into that rubric of induction versus maintenance phase. And in this scenario, I would, well, I'll just leave it at that. That in general, we are successful in 90% of cases achieving remission in our patients. Of course, I'll reemphasize, you got to make sure compliance is not one of the reasons that this is not working. Okay. However, even though we are able to achieve remission, there's still a lot of morbidity that occurs, with either CKD, persistent CKD, or, especially these patients who have cartilaginous involvement by GPA. Some of these patients have persistent tracheal stenosis. Some of them require a trach because they're not able to have their trachea reconstructed, and the damage is permanent. Or the saddle nose deformities are another classic way in which permanent morbidity can happen, even though you've quenched the active vasculitis. Here are some rates of CKD that you can see. You can see that that's quite significant. CKD 3s and 4s, 40% at 7.5 years, with ESRD at the same timeline of 7.5 years and about 10%. Okay, there are instances in which you'll have these so-called double positives, anti-GBM antibody as well as positive ANCAs. You'll see linear staining on immunofluorescence as well, which would be distinct from just, the typical ANCA-associated vasculitis. And people have described a more severe phenotype in these cases. The hypothesis is that the ANCA-associated vasculitis was the first hit with glomerular basement membrane disruption from that initial hit. You then expose neoantigens to your immune system, and then you produce an autoantibody to this GBM antigen. So that is the hypothesis that is provided for these double positives. Again, first ANCA vasculitis, glomerular basement membrane disruption, and then a second autoantibody that is produced to that exposed neoantigen. Uh, uh, I can't speak to that. I can't say with certainty whether there's a higher instance of pulmonary involvement with double positives. I don't know the answer to that.
Wondering if like GPM is like targeting the rest of GPM with the rest.
But the just rest of basement membranes, right, in the body, right? And remember that basement membranes are not composed by the same collagen, but there is this type 3 collagen, or I'm sorry, the alpha chain, the alpha 3 chain of type 4 collagen that is present in the alveolus. That is the antigen that is typically targeted by the anti-GBM. So the anti-GBM antibody, yes. So there are, again, basement membranes don't all have the same type 4 collagen, but there is, again, a presence of this alpha 3 chain of type 4 collagen um, in the alveolar basement membrane as well. Okay, so relapses occur in a good proportion of patients. 30% of patients will have relapse. There is less relapse with MPA versus GPA. That's well described. So GPA clearly has an increased long-term morbidity as well as higher relapse rates, and the two likely go hand in hand. Higher relapse results in higher morbidity. Now there is a tendency for ANCA titers to increase before relapse. Now, there is a bit of controversy here. If you are in rheumatology clinic, they don't typically monitor ANCAs as a routine in somebody who's in clinical remission. Uh, we do, and there are papers that show, this is controversial, some of the papers of ANCA-associated vasculitis generally, whether there's renal involvement or not, show that ANCA is not a great biomarker. ANCA positivity is not a great biomarker for relapse. So that's why that defends the rheumatologist position. Why are we checking these when we don't see clinical signs of relapse? But if you look at some papers in Jason, it was a Jason paper, so high impact papers, looking at renal ANCA-associated vasculitis with renal involvement, there seems to be some predictive value of following ANCAs in predicting renal relapses. So I use that to justify the periodic monitoring of ANCAs in our patients. Now, if I have a patient who's persistently positive, even though they're in clinical remission, I stop checking it, okay, because it's just anxiety provoking. All right. But in somebody who's negative, who with treatment, the ANCAs go down or vanish, I check them to see if they start going up. And if somebody starts going up, I don't pull out my, immunosuppression. I watch them more closely though. Okay. So you have to monitor them more closely, not 6 months, come back. But if you're going to come back in 6 months, I want to do labs, in 2 months or 6 weeks and just make sure that things are not unraveling before your next visit. Okay, so it's a signal to watch your patient. It's not necessarily a signal to bring out a hammer and hit them. All right. Transplant generally has post-transplant patients generally have lower relapse rates, and so we don't worry a lot about relapsed ANCA-associated vasculitis resulting in ESRD in our transplanted patients. Okay, it's generally not something that clearly makes outcomes in this subpopulation of transplant patients inferior to the general population. Okay, so treatment strategies. So there are some scenarios that are really not are relatively refractory to immunosuppression. And I mentioned some of these, orbital involvement, when you have scarring of, the trachea, it generally doesn't reverse. And so, if that's the only manifestation without clear active disease, you don't necessarily bring out immunosuppression. Okay. Now, if I have a patient who has mild EGPA without organ-threatening disease, so these are not patients that we see. Once they have renal involvement, they have by definition organ-threatening disease. But just for larger context, so you know what your rheumatologists are doing, I provide this information that steroids might be sufficient in some of these presentations of EGPA without organ-threatening disease. Again, that's not your world. For drug-induced disease, we withdraw the offending medication, and then we generally immunosuppress, right? But we don't necessarily use a maintenance phase. It would be hard to tell a patient, or it would be hard to muster the courage of, I'm just going to stop your hydralazine and let this, creatinine of 1.7, I'm just going to watch you with there's 20% crescents on kidney biopsy. Most people would say, stop the hydralazine, because you don't know for sure that it's always the hydralazine, right? It could be a red herring, all right? And so you're going to stop the hydralazine. You're going to at least give them induction immunosuppression and then monitor course. Then you have a tougher decision to make regarding the maintenance therapy down the road. So what are these induction regimen that you have? We should be able to get through that. Maybe a little maintenance as well. So glucocorticoids are employed with pretty much all of your induction regimen. You can use quote unquote standard doses with similar dosing to the lupus that I offer you, 1 mg per kg or so for 1 or 2 months, followed by a taper over the 6 months total, such that, by 6 months or so, most of the patients were trying to get off of their steroids. Okay. And then there's the reduced steroid protocol. Now you can invoke a true protocol because this has been studied in a randomized controlled trial. That was a trial of both plasmapheresis, called rituximab, and reduced steroid exposure. So this comes from that rituximab or Pexavas study, study that looked at, again, plasmapheresis. It was a randomized controlled trial looking at plasmapheresis as a favorable intervention, or standard versus reduced steroid exposure. And this reduced steroid exposure comes from the Pexavas study, and our rheumatology colleagues are often explicitly prescribing this. They literally write the prednisone script with this in the pharmacy instructions. So Solumedrol for 1 to 3 days, then prednisone 1 mg per kg for 2 weeks, tapered in this form. I won't read it to you. You can read it. Okay. Now, there is a randomized trial looking at the use of avacopan. Avacopan is a complement inhibitor, actually. It inhibits the C5 as a mobilizer of inflammation, right? This is one of your complement components that stimulates recruitment of inflammatory cells. So avacopan blocks that, and supposedly would result in less steroid exposure. That's what, based on randomized controlled trials, has been found. So you can get away with less steroids if you use avacopan. Solumedrol generally is considered for the severe presentations. That is a art of medicine decision. There's really no, guidelines of when you want to use the Solumedrol. Now, the question of plasmapheresis has evolved over time. We used to think that, it seems to be beneficial if you have a creatinine of at least 5.8 milligrams per deciliter. You might ask yourself, that's an odd number. Where does 5.8 come from? This is 500 micromolar. So in the European or international units, 500 micromolar would be equivalent to a creatinine of 5.8 milligrams per deciliter. And so based on an old trial, there was evidence. It was called the MEPEC study. There was and it was a high impact journal. It was standard practice to offer plasmapheresis for patients with a creatinine over 5.8, and then also without randomized controlled trial data. If you have somebody who's dying of respiratory failure, or if they also have that double positive, that anti-GBM disease, plasmapheresis was typically offered. Now, Pexavas really challenged this, even amongst populations, and that was a larger trial than MEPEX, even amongst the severe AKI patients with creatinines greater than 500 micromolar, there was no clear evidence of benefit of adding plasmapheresis to standard therapy in that multi-center randomized controlled trial. So this has called that into question. And even it looked at patients with alveolar hemorrhage. And so I think still people offer plasmapheresis in the patients who are, clearly have ARDS. I don't think many of us would say don't pherese the patient. Whether you want to do it for severe crescentic presentations is going to be an art of medicine decision. You'll probably use how much IFTA is present. Do you have 80% crescents with no IFTA? You might want to consider it, right? Or if I have, 80% IFTA with a creatinine of 7, I say I don't want to use pheresis in this scenario, okay? If you do choose to do it, you'll basically defer to your transfusion medicine colleagues for the actual protocol, but this is a typical one that they're going to use. Daily pheresis, maybe for 2 days or so, and then every other day for roughly 10 treatments, some 7 to 10 treatments. So it's kind of like a two-week commitment once you decide that you want to start pheresis. And I mentioned, again, this recent data is invoking the Pexavas study, okay, where even with severe renal failure and respiratory failure, there's not clear evidence of benefit. We now have rituximab as a bona fide treatment for ANCA-associated vasculitis. And the data would suggest it seems more efficacious than cyclophosphamide if I have a relapsing course or if I have GPA. Antiproteinase positivity, antiproteinase 3 positivity would imply GPA more often than not. The protocol that you might use is the 375 milligrams per meter squared that comes from the lymphoma literature. And also you can consider the rheumatoid arthritis dosing of 1 gram Q2 weeks. That's what we use because it's fewer doses. Instead of 4 doses, it's 2 doses and you're done. And so it's easier to execute at Parkland. Once again, it does seem data would suggest it is superior to cyclophosphamide for the relapsing or antiproteinase 3 positive patient. Now, cyclophosphamide, if you're going to use it, in my book, should be oral. Even though there's randomized controlled trials looking at IV cyclophosphamide, which the punchline of that RCT says it's equivalent, it's not equivalent. When you looked at long-term outcomes of that study, there were greater relapse with IV cyclophosphamide. So I don't use it. It's also harder to do if you're going to do it like it was done in the RCT. You're not giving it once a month like in lupus. You're giving it every 2 to 3 weeks. It's more burdensome, and long-term data shows there's higher relapses with IV cyclophosphamide. So I've emphasized that, and I don't view them as equivalent. I would always use oral cyclophosphamide if that's what I'm going to use for the patient. Daily oral cyclophosphamide is total exposure that is typically 3-fold higher than IV cyclophosphamide, okay? I think we'll stop there. I think we may have some. Any question? No one there yet? I gotta get to clinic anyway. All right, any questions?